welcome to the Deep Dive. Today we're plunging headfirst into a really critical medical emergency, status epilepticus.
Yeah, basically a seizure that just won't quit or keeps happening back to back.
Exactly. And it's not just a long seizure, it's a dangerous state that needs immediate action.
Absolutely. So to get our heads around how we handle this now, we've looked at quite a range of stuff. We've got an older review from 2002 on ER drugs.
Okay.
Some bits from a more recent podcast discussion on managing it, a 2023 review focused specifically on ketamine for the really tough cases.
Refractory status, right?
That's the one. And, importantly, the big findings from the ESETT clinical trial in 2019.
So think of this as your kind of shortcut to understanding how treatment has evolved.
Yeah.
We'll look at the first steps,
Right.
the main drug options, why one might be picked over another, and dig into why these seizures can sometimes be so hard to stop. It's fascinating biology.
Yeah, our mission really is to lay out the core strategies, the different medications, the tools in the box, why speed is everything, and, well, what happens when the first things you try just don't work.
Okay, let's unpack it. Starting right at the beginning, those crucial first moments, even before specific drugs are given.
Right, so patient comes in, seizing. The immediate priorities, there's a mnemonic for it, A, B, C, D, E, F, G.
A, B, C, D, F, G, okay.
Airway, breathing, circulation, and the D, E, F, G part is don't ever forget the glucose. Really critical.
Okay, makes sense. So first things first, literally life support basics.
Yeah.
Make sure they can breathe, clear the airway,
Positioning, suction if needed.
get oxygen on them, usually high flow.
Yeah.
And at the same time, someone's fighting for 5E access.
Definitely. Need that line in ASP for fluids and, crucially, for the meds.
And you mentioned glucose, that's checked immediately.
Bedside test, yeah. Often called a BM, because low blood sugar hypoglycemia can cause seizures or make them worse. If it's low, you give IV dextrose straight away. Simple fix, potentially life-saving.
There was also a point about thiamine.
Yeah, 100 milligrams store, something to consider, especially if the patient might be malnourished or, has a history of alcoholism. Thiamine deficiency can be a factor.
Got it. And all this happening fast, kind of in parallel.
Oh, absolutely. It's controlled chaos. You're calling for help, getting the IV, drawing bloods, getting oxygen set up, and getting the first-line drugs ready to go. Because while stabilizing, the doc is already thinking, what drug do we use to stop this seizure now?
Which brings us to the traditional first-line treatment. The benzodiazepines.
Benzos. Yep. Been the cornerstone for years. Their main job, as that 2002 review pointed out, isn't stopping the seizure spark, the focus, but preventing it from spreading across the brain.
And they work fast. That's their big advantage.
Super fast. They're very lipid soluble, meaning they cross into the brain really quickly.
Let's talk about the specific ones. Diazepam or Valium, but it was the original, right?
It was called the drug of first choice way back in '65. That older review said it could stop generalized convulsive status epilepticus, GCSE, in about 80% of cases within minutes.
80% is pretty good.
Yeah.
And it can be given IV or rectally.
Yeah, the rectal route is handy, especially outside the hospital, if getting an IV is tough. Peak levels in 5 to 30 minutes that way.
But diazepam has this interesting quirk, doesn't it? Something about redistribution.
Ah, yes. This is really key to understanding it. It gets into the brain fast, like we said, but it's also super lipid soluble and sticks to proteins in the blood a lot, like 99%.
Okay.
So what happens? It rapidly gets pulled out of the brain and into fatty tissues elsewhere in the body. Redistribution.
So fast in, fast out of the brain, at least.
Exactly. That's why its actual seizure stopping effect in the brain is pretty short, maybe only 15 to 30 minutes, even though the drug hangs around in the body for ages.
Right. It has a long elimination half-life, you mentioned.
Very long, about 30 hours. Plus, it has an active metabolite, desmethyldiazepam, which also has a long half-life.
So repeat doses can build up.
Yep. Build up in those fat stores. And that increases the risk of side effects, later sudden drops in blood pressure, breathing problems, even cardiovascular collapse. Plus, that 2002 paper mentioned IV use can cause venous thrombosis, blood clots in the vein.
Okay, so diazepam, fast onset, but short brain action and accumulation risks. How does lorazepam compare?
Lorazepam came later, chemically slightly different. The big advantage highlighted in that review is minimal redistribution.
Meaning it stays in the brain longer.
Exactly. Therapeutic levels stick around in the brain much longer. Its anticonvulsant effect is reported to last well over 24 hours sometimes.
Why the difference?
Less protein binding, smaller volume of distribution. Basically, it doesn't get pulled out into body tissues nearly as much as diazepam. One study mentioned found it stopped seizures within 10 minutes in all 9 patients. Another plus. no active metabolites.
Sounds better in several ways. Any downsides?
Well, rectal absorption isn't as reliable, and the IV form needs refrigeration, which makes it less ideal for, say, paramedics compared to rectal diazepam. And crucially, it still carries the risks common to all benzos: respiratory depression, hypotension, and they all can make the patient quite sleepy, which can make it harder to assess their neurological state afterwards.
Got it. What about midazolam?
Midazolam, water-soluble benzo, much shorter half-life, only about 2 hours. Like diazepam, it's got a rapid onset, works quickly.
Shorter duration of action. Is that good or bad?
Can actually be good. Because it wears off quicker, you can often get a clearer picture of the patient's underlying neurological functions sooner after the seizure stops. It's also good for continuous IV infusions if you need ongoing sedation.
And it seems particularly versatile in how it can be given.
Yeah, that came up in the sources. Bacal inside the cheek works well, especially pre-hospital or in kids. Comparable to rectal diazepam. Intramuscular is an option too because it's water-soluble. And intranasal has shown promise, particularly for kids' febrile seizures. Some suggestion it might even be useful when other things fail.
Clonazepam was also mentioned briefly.
Yes, another option, usually given as an IV load. There was one study comparing it to lorazepam, suggested maybe lorazepam improved the EEG faster, but clonazepam gave more complete clinical symptom resolution, kind of nuanced differences.
Okay, so several benzo options. But what's the absolute key takeaway for using them as first-line treatment?
This is probably the most important point across all the sources for this stage. It's less about which benzo you pick, or even sometimes the route, and much more about how fast you give it. Time is critical.
All right.
The longer someone seizes, the harder it becomes to stop. The brain chemistry actually changes, making it more resistant, refractory to treatment.
The podcast excerpts really emphasized that, did they? Calling underdosing and dosing too late major pitfalls.
Absolutely. Some docs even say don't wait for the formal 5-minute definition of status. Treat aggressively and early. 5E push, adequate dose. A good tip was drawing up a second dose right away so you're ready if the first one doesn't work in a couple of minutes. No delays.
And benzos are also the first choice for alcohol withdrawal seizures.
Correct. That's another key indication. So the initial game plan: stabilize ABCs, check glucose, and get a benzo in fast.
But sometimes, even with quick administration, they don't work. What's the next step?
Yeah, unfortunately, they fail in a fair number of people, maybe a third of kids, up to 40% of adults, according to the info we looked at. If the benzo doesn't stop it, the patient is now an established status epilepticus.
And this is where you have to worry about seizures continuing even if the shaking stops.
Exactly. Non-convulsive status epilepticus. Big concern. If the patient isn't waking up, not returning to near their baseline mental state within roughly an hour after the convulsions stop, you have to suspect it's still happening electrically in the brain. Need to keep treating, and ideally get an EEG on them.
So first line fails, we go to second line, and the ESETT trial really clarified this stage.
Hugely. ESETT established Status Epilepticus Treatment Trial 2019, landmark study. Randomized patients who didn't respond to benzos to get one of 3 drugs: levetiracetam, fosphenytoin, or valproate.
And the big news from ESETT was
No significant difference between the 3. All worked, and about half the patients stopped the seizure and improved alertness by 60 minutes. The trial was actually stopped early because it was clear none was going to prove significantly better than the others.
okay, so ESETT tells us we have 3 basically equivalent main choices for second-line therapy. Let's look at them. Phenytoin and its cousin, fosphenytoin.
Right. Phenytoin's an old drug, back to the 1930s. That 2002 source mentioned claims of it working in up to 90% of cases, though maybe take that with a grain of salt. It gets into the brain, but slower redistribution than benzo, so longer action.
But it's got a notorious side effect, especially when given quickly.
Absolutely. Infuse it too fast, and you risk hypotension, low blood pressure in a big chunk of patients, maybe 28–50%. And cardiac arrhythmias in maybe 2%, especially risky in older folks or those with heart problems. It's also really caustic, irritates veins, can damage tissue, can't give it IM at all.
But a potential upside mentioned was
Unlike benzos, it doesn't usually knock out their breathing or heavily sedate them at normal doses. That's a plus.
so infusion rate is critical, max 50 milligrams per minute.
Yep, and even then, it might take up to 30 minutes for the full effect after it gets into the brain. That's why it was often suggested to give it with a benzo, use the benzo for the quick stop, and the phenytoin for the longer hold.
And fosphenytoin was developed to get around some of those issues.
Exactly. Fosphenytoin is a prodrug. It's converted to phenytoin in the body. It's water-soluble, less irritating pH, so much less vein irritation. Can be given IV faster, up to 100 milligram PE per minute, reaching therapeutic levels quicker, maybe 10 minutes, and you can give it IM too.
Still carries risks, though.
Yes. Still phenytoin underneath. That 2002 review mentioned serious cardiac events reported globally, even cardiac arrest, though sometimes linked to excessive doses or rates. The risk isn't zero.
And crucial times not to use either phenytoin or fosphenytoin.
Absolutely. Critical pitfalls mentioned. Don't use it if you suspect a toxic cause like TCA or cocaine overdose. They block sodium channels. Phenytoin blocks sodium channels. Bad combination can worsen heart problems, cause collapse. Also, if the patient's already on phenytoin daily, loading them with more IV is probably not going to work and just cranks up the toxicity risk.
Okay, so fosphenytoin phenytoin is one ESETT option. What about levetiracetam?
Levetiracetam Keppra is a common brand name. The other ESETT equivalent worked in about half the patients after benzos failed. Dose in the trial was 60 milligrams per kilo FE, up to 4,500 milligrams max.
And the third one, valproate.
Valproate, or valproic acid, also fifing. The 2002 source mentioned it as an option for resistant seizures, maybe an alternative to barbiturates as it's less sedating. ESETT confirmed it as equivalent to the other two, same roughly 50% success rate. Dose there was 40 milligrams per kilo, 5, max 3,000 milligrams. Big caveat, though. Absolutely contraindicated in pregnancy, and there was a mention of potential severe hypotension in a child in one report.
So levetiracetam, fosphenytoin, valproate, the main ESETT3, basically interchangeable based on that trial. What about propofol as a second liner? It came up in the podcast info.
Yeah, propofol. It's emerging as an option here, though maybe less robust trial data specifically for second line compared to the ESETT3. It's widely available, works very fast, and crucially, it's seen as safer in those toxic overdose situations where phenytoin is in no-go.
How's it typically used?
Usually a bolus dose, maybe 2 milligrams per kilo, then a continuous infusion. The dose range mentioned was 50, 80 mics per kilo per minute, something like that. But the big trade-off, it causes significant respiratory depression. Patients often need intubation and can drop blood pressure quite a bit.
And the concern about it causing seizures.
Seems mostly debunked. What people might have seen was probably myoclonus, muscle twitches, not actual seizure activity.
Okay, so second line gives choices. ESETT leveled the playing field for 3 key players, and propofol is another tool, especially useful sometimes. But what if those fail too?
Right. If you've given adequate doses of a benzo and an adequate dose of one of those second-line agents, and the seizure is still going, now you're in refractory status epilepticus. By some definitions, that's usually after about 40 minutes or so of continuous seizing.
And this demands ICU-level care.
Absolutely. Needs to go to the ICU. The drugs you need now are potent anesthetics, basically, and they carry significant risks of cardiovascular instability, breathing problems. You need intensive monitoring. And continuous EEG monitoring becomes really crucial here to see if you're actually stopping the electrical seizure activity, even if the patient isn't moving, and to guide how much drug you give.
So what are the main options in the refractory stage?
Usually involves continuous OV infusions. High-dose midazolam infusion is one option. Barbiturates are another, things like thiopental or phenobarbital. Propofol infusion, often at higher doses than second line. And the sources also brought up ketamine, lacosamide, and in really extreme situations, consulting anesthesia for inhaled anesthetic gases.
Phenobarbital is an older barbiturate.
Yes, mentioned in the 2002 review. Some older studies suggested it could work well. Loading dose 10 milligrams per kilo to first, given slowly. But lots of caution needed, especially if benzos were already given big risk of cardiovascular collapse. Major impact on breathing, consciousness, blood pressure. Generally reserved for when benzos and phenytoin fail, and definitely needs an ICU setting. Pentobarbital and thiopental are other barbiturates, also with significant side effects.
And at this refractory stage, you really have to double-check. Is it definitely seizures?
Excellent point. Pseudostatus non-epileptic seizures becomes a really important consideration. Are there clues? Maybe episodes lasting over 90 seconds, eyes tightly closed during the seizure, pupils still reacting, fighting you opening their eyes, a history of similar events or other unexplained symptoms. It needs to be considered.
And paralytics, sometimes used.
Yes, agents like rocuronium or succinylcholine. But not to treat the seizure itself. They're used mainly to help with intubation if needed, or more often in this context, to stop the muscle contractions so you can get a clean EEG tracing. This lets you see the underlying brain activity clearly and adjust the sedatives properly. The paralysis helps with monitoring and ventilation. It doesn't stop the brain seizure.
Okay, let's give it slightly and really focus on ketamine now, drawing from that 2023 review, especially for refractory status.
Right. Ketamine comes from phencyclidine, synthesized back in the 60s, used as an anesthetic. But its use for status epilepticus really only started getting reported in the 90s.
And its mechanism is key here, isn't it? Targeting NMDA receptors.
Exactly. That's its main relevance. Ketamine blocks NMDA receptors, which are a type of glutamate receptor. Glutamate is the main excitatory neurotransmitter in the brain.
And this ties to that concept of receptor trafficking you mentioned earlier, why seizures become resistant.
Precisely. This is the core idea from that 2023 review. When a seizure goes on for minutes, the brain starts physically changing things on the nerve cell surfaces. GABA receptors, the ones that cause inhibition, where benzos work, they get pulled inside the cell, internalized. Fewer GABA receptors on the surface.
Making benzos less effective.
Right. And at the same time, glutamate receptors, particularly the NMDA type, get pushed out onto the cell surface, externalized. More excitatory receptors.
Wow, so the brain literally rewires itself on the fly to be less inhibited and more excitable.
That's a great way to put it. And this biological shift provides a strong rationale for why NMDA blockers like ketamine might work when GABA drugs like benzos are failing. You're targeting the receptor system that's become more active, more prominent during the prolonged seizure. It's hitting the problem where it's currently happening.
Makes perfect sense biologically. What does the actual clinical evidence show for ketamine in refractory SE?
Well, here's the limitation. The evidence, as that 2023 review makes clear, is mostly from case reports, case series, retrospective studies, so it's lower quality evidence compared to big randomized trials. Studies are often small, use different doses, different patient groups. It's quite mixed, heterogeneous.
But within those limitations, has it shown any effectiveness?
Yes, it has. Looking at those collections of cases, ketamine did appear effective in controlling seizures in refractory and even super refractory status, the really, really tough cases. One analysis found it gave complete seizure control in about 63% of cases, partial control in another 31%. Seems to work within a few hours, and maybe higher doses work better, though that's not definitively proven.
Any major downsides seen in these reports?
One issue that came up repeatedly was seizures coming back after stopping the ketamine. Happened in a fair few cases, maybe 10% up to 60% in some series, so recurrence is a potential problem.
And the dosing was all over the place.
Very much so. Highlights the lack of a standard approach. Loading doses were used sometimes, but the amounts varied hugely. 4 infusion rates were incredibly wide-ranging, from tiny amounts to quite large doses per hour. Even some reports of using it enterally via the gut, though absorption that way is low, and treatment duration could be anything from hours to almost a month.
What about side effects?
Various things were reported: transient high blood pressure, fast heart rhythms, problems with coordination, cerebellar syndrome, metabolic acidosis, which sometimes seemed linked to getting midazolam at the same time, and even cardiovascular collapse in a couple of cases. But it's really tough in these super sick patients getting tons of drugs to be sure ketamine was the sole cause of any specific adverse event.
It's interesting, though, that unlike many other anesthetics used here, ketamine often raises blood pressure and heart rate.
That's a really notable difference. It tends to stimulate the sympathetic nervous system, releasing adrenaline-like substances. This can be helpful, as other agents often drop blood pressure. Although, confusingly, there are also some suggestions it might occasionally weaken heart function. It generally doesn't seem to raise pressure inside the skull, and might even reduce the need for blood pressure support drugs, which is a potential plus.
So summing up ketamine, what's the case for it being promising, despite the evidence gaps?
The strongest argument is that biological mechanism, it directly targets the NMDA receptor upregulation that happens in refractory seizures. It makes sense. Plus, its side effect profile is often different from other agents. It tends to maintain breathing drive and airway reflexes better, maybe reducing the immediate need for intubation compared to high-dose barbiturates or propofol. And ER and ICU staff are often already familiar with using it for sedation or pain. Animal studies also suggest it might protect neurons.
But the big but is the lack of high-level evidence and standardization.
Exactly. No big, definitive, randomized controlled trials comparing it head-to-head in a structured protocol as, say, a standard third-line therapy. The mixed data on dosing and outcomes makes it hard to draw firm conclusions. Safety profile needs more study in this context, and that lack of top-tier evidence makes it hard to formally write it into standard treatment guidelines, even with the compelling biology.
Which brings us right back to that provocative question from the review.
Ugh.
If the biology shifts like this during prolonged seizures,
Making benzos less effective and NMDA blockers theoretically more effective.
should we be thinking about using drugs like ketamine earlier?
It's the million-dollar question, isn't it?
So wrapping up this deep dive,
Yeah.
as you've clearly heard, scatus epilepticus is a massive emergency. Time is absolutely brain.
Yeah, that risk of permanent damage, that T2 time point, starts kicking in potentially after just 30 to 60 minutes of nonstop convulsive seizing. Getting treatment in early and effectively is just paramount.
And understanding that sequence of therapies, starting with the fast benzos,
Moving to those equivalent second-line options proven by ESETT.
and then having strategies like continuous infusions, maybe ketamine for the refractory cases, it really shows you how complex, but also how strategic managing this condition has to be.
It really is a race against the clock. Doctors are constantly juggling the need to stop the seizure with the risks of the powerful drugs needed to do it, all in a very high-pressure situation.
So what does this all mean for you listening to this? We've traced the evolution, haven't we? From relying heavily on diazepam.
To having multiple benzo options, and then ESETT giving us those 3 solid second-line choices.
And we've dug into that really fascinating brain biology, the receptor trafficking that explains why seizures become refractory.
Yeah, and how that provides such a strong scientific reason to consider drugs like ketamine that specifically target those upregulated excitatory pathways.
But as we saw, the high-level clinical trial evidence for ketamine in this specific role is still lagging behind the biology, creating a challenge for putting it into standard protocols right now.
So here's that provocative thought to leave you with. If the basic science tells us that the longer a seizure continues, the less well traditional GABA-acting drugs work, and the more relevant NMDA blockers like ketamine become, does that biological truth suggest we should seriously rethink the order we give these drugs? Maybe bringing NMDA antagonists in earlier, even as we wait for more definitive trial data. It's a real tension between the science we know and the evidence we currently have.